Good morning. This is the meeting of Baltimore City Council Education Workforce and Youth Committee. It's now called to order. I am Councilman Robert Stokes, representing the 12th District, and chair of the committee. In attendance, we have member of the committee, Councilwoman Felicia Porter from the 10th District. We also have the committee member Trey Hayes. Thank you. I'm gonna just read the actual resolution. For the purpose, invited representatives from the Baltimore City Public School System, the Baltimore Health Department, the Maryland Department of Health, and the Mayor's Office of Children and Family Success, and other relevant stakeholders discuss development, expansion, and preservation of school-based health clinics throughout the Baltimore City school system. Today, the committee is holding a hearing on Resolution 23-000R, information hearing school-based health clinics. Before we start, I'd like to give the sponsor of this resolution, Councilwoman Felicia Porter, some opening remarks.
Thank you, Mr. Chair. According to the Maryland School-Based Health Center Program Needs Assessment, Baltimore City ranks within the top 3 counties across the state with the greatest immediate gaps in healthcare access or highest prevalence of childhood disease conditions such as asthma and depressive symptoms. While Baltimore City is home to about 50% of the school-based health centers, today's discussion remains a critical issue because of the ongoing public health disparities and harsh conditions that burden our communities. For the past 5 years, our office's top priority has been to build healthy communities. But for far too many families, especially those in underserved areas in which I serve, access to quality health care remains out of reach. Additionally, the lack of readily available medical services creates a ripple effect. By establishing new school-based health centers or expanding the existing school-based health centers, we not only have the opportunity to proactively improve access to quality health care and student access, but we can also reduce risky behavior and chronic absenteeism. This is precisely why I'm proud to sponsor this bill on expanding school-based health centers. These centers are beacons of hope, providing vital services such as routine checkups, immunization, mental health counseling, and dental care, all within the familiar walls of a local school. Excuse me. However, the current distribution of these centers paints a more concerning picture. While we see a concentration of these centers throughout the city, they're non-existent in some areas like South Baltimore, which lacks adequate healthcare options. This bill attempts to change that. By strategically allocating resources and fostering partnerships with local health providers, we can bridge the gap. The expansion of the school-based program network will align our efforts to end child poverty at the local and state levels and improve our overall healthcare infrastructure across Baltimore City. Thank you, Mr. Chair.
Thank you, Councilwoman. And real quick, I'm not want to tell my age, but over 20 years ago, I started a program. It's called the Oliver School-Based Asthma Program. And at that time, it was in 4 elementary schools because I knew when I grew up, my mother had to rush me to the hospital because I had asthma that bad. My son had to rush him to the hospital when he was 1 year old and put him in this plastic zip-up thing so he could breathe. And I know a lot of young people miss time from school because they end up in the emergency room. And, you know, a lot of times, I finally, at my age, I went and got an asthma test and found out exactly what you're allergic to in your house, around people, around cat head, dog head, carpet head, a whole lot of stuff. So even though that program didn't get funded, I think we need to go back and look at how we now put the asthma program back into our elementary schools, because it was a 6-week program and it taught the parents and the kids about symptoms of asthma. But when you go home, things to look for when your asthma trigger. A lot of the high schools have what did you call it the kids use when they have an asthma attack? Is that? Inhaler, but I didn't know it was called inhaler. But they're not in the elementary schools from my understanding. They're mostly in the high schools. First of all, well, that's what I was told. They're mostly in the high schools, not in the elementary schools. In the elementary schools, not in the high schools. Well, I'll get it right, but I just want to share that because back then, when we went up to the health department on North Avenue back then, before your tenure, a lot of the folks at the health department didn't know that was an issue in terms of kids missing time. And we met with the health department. We were able to have it in 4 elementary schools, but I think we need to go back and revisit that because our kids are missing time from school right now. Thank you.
Thank you so much for that, Mr. Chair. I just also want to build upon that with regard to the asthma programs that the City Health Department does sponsor that's in our school-based health. So, you know, while we have children in Baltimore City Public Schools that are suffering from chronic illnesses such as asthma, we have an opportunity here to expand the model to school-based health centers. So thank you for that.
Thank you. So agency reports the city solicitor is favorable. The Baltimore City Schools is presenting. The health department is favorable. So we're gonna start with our presentations and I'm gonna go by what's in order. When we start, we're gonna start off with Baltimore City Schools gonna do a presentation. The health department with our health commissioner, the Maryland Department of Health, Dr. Warmer, Maryland Department, the Maryland Department Commission, Mark Lochner, and Dr. Dobson from Dobson DeVito. So Baltimore City Schools will be presenting first.
Great, thanks. I'm happy to kick it off. Do you want people to present from here, or do you want us to go up? Whichever you prefer. Okay, great. So thanks for inviting us and for calling this meeting on this important issue. I'm Allison Perkins-Cohen. I'm the Chief of Staff for City Schools. I'm going to kick us off just briefly, and then I'm going to turn it over to Dr. Pate, who's the expert, to go through this. We're really happy, again, to be here to talk about this issue and about health services in general. I want to first thank our partners at Baltimore City Health Department and Dr. Manuga and her team, who have been longtime partners in this work. I also want to thank Dr. Connor from the Rails Department. Dr. Connor and Dr. Pate just a month or so ago had a health symposium at Johns Hopkins about school-based health services, and I was remiss at that time not recognizing Dr. Connor with the many people I was thanking, but just she's been an invaluable partner to us through the Rail Center, as well as during the pandemic. She served on our health advisory committee, so she's been a tremendous partner as we're trying to get better at providing better services to our young people. And I also want to thank the chair of the Education and Youth and Workforce Committee, who's been a tremendous partner to City Schools. I appreciate his leadership in this role, as well as every time we've called him or needed partnership or a thought partner or assistance, Councilman Stokes has always been very helpful to us. So I just wanted to thank him. So just as a quick intro, first, just want to give a little bit of the landscape of the school-based health situation in Baltimore City Schools. So historically, we have always had an MOU with the Baltimore City Health Department, who provides the health services in our health suites or centers. And the BCHD has always had a staffing model where they have assigned one RN to a cluster of schools, and those schools then have had nursing assistants or LPNs who provide the day-to-day services at those schools. The Blueprint for Maryland's Future has had a big impact on all of us and how we're thinking about providing health services, because one of the major requirements for health suites there is that schools are increasingly required to have a registered nurse on site. That change in law came right at a time when there's been a national nursing shortage that was then exacerbated by a global pandemic. So that's been a challenge as we've all tried to figure out how to meet that staffing requirement. Over time, then City Schools has taken over some of the health suites, and I will turn it over to Dr. Pate to talk about that. And I just want to also give kudos to Dr. Pate and her leadership. We were fortunate enough to court her away from BCHD during the pandemic when we were really struggling to figure out how to serve young people, and she's been a great partner in terms of trying to figure out how to be innovative and creative about improving the health for our young people. So with that, I'll turn over to Dr. Pate.
Good morning, everyone. I am Dr. Courtney Pate. I'm a PhD prepared family nurse practitioner, and I have the pleasure of serving as the Director of the Office of Health and Specialized Student Services at Baltimore City Public Schools. So in school year 21-22, city schools provided 3 nurses in health suites throughout the city. The following year, there were 12 schools that did not have health suite coverage at the beginning of the school year. So we utilized our nursing contracts and leveraged them to provide nurses in those schools. By the end of that school year, it had elevated to 19 schools that we had become responsible for. In an effort to be proactive and not have this snowball effect happen the following year, we went to our friends at the health department and said, next year we'll take 35 schools. We didn't have a school health services infrastructure. I was the school health services infrastructure, but fortunately over time we have been able to build that up. So now we have a manager of nursing operations as well as 2 nursing supervisors who coordinates the day-to-day of the 35 schools that we operate. Seeing as how we didn't have a traditional school health structure and we were trying to figure out innovative ways to expand our reach and make sure that we could provide our students with the best care that they deserve, we developed the university partnership with Hopkins, Morgan, and Coppin. We put out an RFP asking all the local universities who had a school of nursing if they were interested in partnering with us. It was important that we utilized a school that had a school of nursing because we also had a goal of developing a pipeline, because school health, as most nursing career paths, is a specialized career path. Not many people go to nursing school and are like, I want to be a school health nurse. No, they say, I want to work in the operating room, the emergency room, labor and delivery, all of the cute, flashy places that you see. Most people, unless you're me, are not like, yeah, school health is where I'm going. I knew that's where I was going from the onset of my trajectory. In addition to these university partners providing care at 15 of our schools, they also are dedicated to providing CTE pipeline experiences for our students who are in our health pathways, one of which was at the symposium which we hosted last month. We had a chat and chew with some students from Emerson Westside High School who are in health pathways. It was a very great experience for not only us, but for the kids as well. They got to ask some insightful questions about what it takes to be a nurse or to be in healthcare, as well as just get poured into and understand that we all of us in the room pretty much started from the same backgrounds that they were from and gave them the beacon of light that they could be successful as well. So currently, Coppin is in charge of Harlem Park, James McHenry, Hilton Elementary, Windsor Hills, and Coppin Academy. Morgan State provides health suite services at Hampton, Garrett Heights, Roland Park, Glenmount, and Northwood. And Hopkins hosts Commodore John Rogers, Mount Royal, William Packer, Fort Worthington, and John River. People often ask, like, what went into this decision for these people to have these schools? So the first thing was if they had already had a footprint in that community, we asked them to pick schools in the community where they had a footprint. In addition, traditionally with having a school health aide in a health suite, when a student has a complicated health condition or something that can't be managed through delegation, city schools was providing a registered nurse or a CNA to be with that student as a one-on-one throughout the day, which is a very expensive endeavor to continue. Our budget was about $8 million every year for private duty nursing. What we realized as we went through what we were providing private duty nursing for, some of those conditions could have been cared for by a health suite if a registered nurse was there 5 days a week. So we started with our schools that had the highest utilization of a private duty nurse for services that could be done by the health suite. So it's been a huge culture shift, especially for our parents, because we've had to explain to them, like, the reason why your child had this was because of this, but now we've put something in place to care for them, someone in place to care for them day to day, and they will be taken care of. So we've been working towards massaging our families into becoming more comfortable with their child's conditions being handled by the health suite. A lot of these kids were our diabetic kids who required insulin via injection, though that was not delegated to school health aides. So having a registered nurse there every day, they're now getting the care that they need. Next slide, please. So just to give the current landscape of our health suites that are operated by the Baltimore City Health Department. There are 101 traditional health suites that use the Health ARM model. I pulled Bear out because Bear is our one special health suite that has always been staffed by multiple registered nurses based on the complex care needs of those students at that separate public day school. There are 4 school-based health centers that are operated by the Baltimore City Health Department, which are Augusta, Fells, City Springs, Reach, and Digital. 1 school-based health center that's operated by Hopkins Rural Center at KIPP. And there are 9 school-based health centers at 8 sites that are operated by Baltimore Medical System. So Fairleigh Vanguard, they are a shared site, but 2 separate school-based health centers. Then you have Hartford Heights, Tench, Collinton Square, Dunbar, Forest Park, Patterson, and Maryville. So currently, City Schools does not operate any school-based health centers, and quite honestly, we don't have the infrastructure to do it. You have to have labs set up, medications set up, providers to pay for, so it's an endeavor that we don't have the infrastructure to take on at this time.
Real quick, and I'm glad you said that, because the school system has been charged, saying they're responsible for the health clinic nurses in the school. So I'm glad that piece is in there, because it get a little confusing. Because you say school system, they think it's the school system responsibility. So I'm glad that piece is put in. Thank you.
No problem. Next slide, please. So plans for the future, right now we're in a process of hiring 20 full-time nurses. The past 2 school years that we've done school health, we've relied on agency nurses, and we just feel as though our kids could get better care if those nurses were direct employees of city schools. So for the first time in city schools history, we are hiring nurses. We also have plans to develop a school health training program for those nurses. We're going to do a boot camp, and we'll open it up for health department nurses as well as those university partner nurses to attend, so that we're all on the same page. In partnership with BCHD and the university partners, we're seeking to revamp our school health services manual. So again, we're all on the same page. We're moving to utilize Infinite Campus to record and document school health suite visits. Currently, we use a WebEx-based system that needs to be obsolete. So if we move to documenting everything at Infinite Campus, both the health department and city schools will have direct access to student health records. And we also look forward to collaborating with our school-based health center partners.
And I had a quick question on that. So both agencies would be able to utilize this particular program to share data and information from the school-based health centers to the schools? So everything would be
Not school-based health centers, from school health suites.
from school health suites to
City schools.
city schools?
So right now, city schools has access to it, but it's not widespread access. So
Okay.
oftentimes they have to come to me and say, hey, can you get me the school health visit
Okay.
from X date? We're trying to make that not a thing anymore, and at least our Office of Legal Counsel will be able to just log in. and get
Perfect.
that
So the
information.
interoperability between everybody would be secured?
Yes.
Okay, perfect.
Real quick, before you start, I want to acknowledge Councilman Bullock, member of the committee. I think he don't have his bow tie on today. He look a little different, so.
Can I also do an acknowledgement? I want to acknowledge Commissioner Mohammed, who joined us in the front row here from our Board of School Commissioners.
Next slide, please. I think that's it.
Yeah.
Thank you so much for that presentation. It was very informative. One of the opportunities that I believe we have for Baltimore City Public Schools is precisely what you hinted on, about expanding our health suites along with our school-based health centers, kind of working in tandem together. And I'm hoping that through this particular discussion, we kind of figure out what those recommendations are. Who do we need to tap upon, whether it be from the state, the Maryland Department of Health, the Maryland Services Commission, so that we can kind of get that funding gap, because apparently you're going to need a funding gap or a funding, some funding for not only the 20 additional nurses, but also the integrated medical teams that are going to be coming with those nurses that I hope will be kind of integrated as well. I did have one question related to community health workers. I have been on just a really deep dive into community health workers being a part of the school-based health centers in Baltimore City. Can you speak to what that would look like, or how that can be integrated, or if you already have been integrating that into the model?
So I know for Baltimore Medical Systems, they do have some community health workers who are integrated, especially at Patterson, to help with making sure that those students in that area access healthcare. I know that there's a model through the consortium with Kate at KIP around utilizing community health workers. One way that we've kind of explored potentially using community health workers in Baltimore City is so many different ways to access healthcare or enter healthcare that people often get stuck and don't know where to go or what their next step is. So through the consortium, we had explored utilizing community health workers specifically around mental health.
Okay.
As like family navigators, so to speak, to say like, hey, Mikey needs help with his mental health. Let's go this pathway because this works best for you based on the resources we have within that community.
Yeah, that actually makes me really happy, and I wonder if there can be an opportunity to expand it to the non-communicable diseases as well, like diabetes. I had brought that up in a previous hearing. Given that it's a chronic disease that impacts many of our youth, I wonder if we can have that same model for like the diabetes, because that'll bridge the gap between massaging families into the fold now, you know, and you would necessarily build that rapport that they already have within the communities. And I'm wondering, those high school students that you are using, I'm wondering if that can be the first rung of their interest or their integration into healthcare and then going into that school-based model. So it just provides a much easier pathway than just like being a nurse. Like there's so many other avenues that we can explore.
Thank you for that.
I have a question, and I'm looking at, you said some of the colleges in Hopkins that are providing. So the footprint for Hopkins, you have number of schools, but you have Johnson Square, Hartford Heights, and Dr. Bernard Harris, who are 5 minutes or 10 minutes away from Hopkins, and they're not on this list. Is there a reason why?
Because they weren't a school that utilized private duty nursing to meet the needs of their students. So while they are within the Hopkins footprint, with this, we started with those that were high utilizers of private duty nurses. So we started pretty much with the schools where our sickest children are attending and worked our way from there.
Okay, thank you.
And also,
Councilman
just,
Bullock?
there was a capacity limit in terms of, you know, how many schools that we could take on with university partners, and this is all, again, providing any health services is really new for city schools, so having 35 health suites is very new for us and a big deal. And so this university partnership was, as Dr. Pate mentioned, a way for us to really work with partners who can help us make sure that we have that, that we're staffed, because that's an issue. Finding nurses is really challenging, so they have nursing students who can staff, but also help us identify best practice and try to think how to do things better. But it was really to Dr. Pate's leadership that really looking at the profile of our young people to try to figure out where those partnerships could best mitigate other costs we have and inefficiencies. It's not really helpful for, it's much better if we have nurses who can provide the full range of care that the young people in that school need, and that's what we were able to do with these partnerships.
And that's exactly right, Allison. One of the hopeful opportunities for the expansion with the Kerwin dollars is that we kind of replicate what you all have done, and then kind of replicate it in other schools and seeing how we can use not only just nurses, but also other health practitioners to be in those schools, and maybe combining with telehealth options to kind of connect the network and infrastructure as well.
Real quick, before you go, Councilman Bullock, last time we had a hearing, we talked about the shortage of nurses, and it's not just the salary. Last time we had a hearing, I said, are we doing incentives with housing to create maybe a grant, excuse me, like $20,000 for somebody to come on board and be a nurse in the school system? You got to put some more incentives, because evidently the salary is not working. They can go and work at a hospital and probably make more money. So have y'all made any inroads in terms of talking to housing to create? Because we did that with our law enforcement. Like if they move into the city, they get a grant in terms of moving into Baltimore and buying a house in Baltimore. So I was wondering, had y'all looked at that? If not, I think that'd be another incentive to probably try to recruit more nurses into our schools.
Yeah, so we haven't done anything on housing. The health department, perhaps, maybe they've looked into that. We did work on our salaries a lot to make sure that they were more competitive. So we have worked on that avenue. And then again, that's why we really tried to be really creative about things like these partnerships where there are students. And so again, it helps with the immediate staffing issue with the current nursing students, but it's also exposing them, as Dr. Pate said, to the world of school-based health. And while yes, hospitals often may pay more, it's also there's trade-offs in terms of being able to have relationships with young people in a school setting, a consistent relationship with young people, serving young people and serving communities. There's things that about school-based health services that I think are appealing, and just getting exposure to current students as well as then giving exposure to our students, giving that pipeline for our students to explore that and develop opportunities for them. So that we just felt it was a win-win-win opportunity to create these partnerships, and so we hope that's one way to try to attract more folks, but certainly are open if the council is considering options for housing, and we don't do much with regard to housing, but if there's ways that the council is considering that, we'd be very open to that.
Thank you, Councilman Bullock.
Thank you, Mr. Chair, and apologies for being a little bit late. But again, I think there's a lot just to be encouraged about today. I will say it's also good to see the collaboration between city schools and the health department, because we look at folks who are experts in those particular areas. I'm thinking about a couple of the questions that I know were asked earlier, particularly by Councilman Porter, as about community health workers and thinking about community connections. Couple questions that I do have, and I observed that some of this is around staffing. Some of it could also be about space within schools. But first, the university partnerships, which I think are great. How long have they been in place now? And I apologize if I ask a question that had already been answered, but how long have those partnerships been in place?
It just started. We got our contracts finalized in February.
And then what is the length of the contract?
3 years.
3 years. Okay. And then in the next couple of years, obviously, we're going through the process with 21st century schools. And I see Councilman Torrance walking in, so I'm going to ask a question related to one of his schools. But we look at something like Frederick Douglass, for instance. And I know going through that process, there have been conversations around what that space will look like. Can you talk a little bit about how we're looking forward with city schools in terms of not only the space for health centers, but also the connection to community, because it can be a challenging piece if we're talking about walk-ups versus school and dealing with the school population. Can you guys talk about that a little bit too?
Yes, so in the case of Frederick Douglass, all of our 21st century buildings have the specifications, ed specs have a health suite in them. In the case of Douglass, there's enough space in there that it could be, there's a square footage difference between a health suite and a health center that you have to address. And in the case of Douglass, there is enough space in there. We've modified the design so that it could be a health center if there is a provider. That is a health suite that's run by the health department, and so they are the ones who would be, making that determination, and they have indicated a willingness to go through their own selection process to identify a potential provider for that health center that then would have to go through the state process to select whatever the state process is to become a health center. And then we would, if that works out, we could then build the health center that way. We have time. The Douglass School swings into swing space in the fall. It doesn't actually open until 2026. And so right now the space is allocated in the design. And so I've talked to the Maryland State Authority about this and how much lead time they need to know whether to actually build it out as a health suite is probably about a little bit less than a year before the school opens.
Okay, and then just one quick follow-up to what Chair Stokes had mentioned. Thinking about the schools that may not already have a program set up, what is your thought in terms of what that looks like in the future, moving forward with those schools that may not have a center right now?
So you mean 21st century, you're being specific?
No,
to,
just
all schools?
All schools, yes.
So again, one of the limitations would be space. So if they don't have space, that's a limitation. One thing we've thought about is looking at schools that actually physically have the space already to see if and again, most of those would be the health department health suite. So in conversation with them, whether they would want to look for a partner. I think the key, and Dr. Manuga can speak to this, I think the key for the health department and certainly for city schools is that if we're finding a health center partner, it can't add additional costs to the health department or city schools. And it has to provide both the health, another really important point is it has to provide health center services and health suite services. We run a model where it provides both. And so that can't have and when I say we, I really mean the health department because we don't run health centers, but it has to provide both. And so that's something that they have to be willing to do both those things at no additional cost to the two departments.
I know the cost is key, so thank you for sharing that.
I just want to acknowledge Councilman Torrance from the 7th District, member of the committee. Our next, you have a question, Council?
Thank you, Mr. Chair. So this is both the city schools and the health department. My biggest concern from being a former employee at city schools is understanding not only how the shared cost is going to occur, as well as with third-party billing. So I would like to understand that from a perspective, because if a potential vendor is entering into a school, there are two things. If you're going to do with the mixed model, there's certain portions of it that will go to city schools as third-party billing. Some will go to the shared partner. How are we going to handle that in terms of financing?
And if I can interject here, Dr. Connor, I believe we actually have that embedded in the presentation. So can we actually save that question for the next presentation and then go from there?
Okay.
All right, thank you.
Okay, our next presenter will be the Baltimore City Health Department, Dr. Emanuga. And can you introduce your staff if you have any here? Thank you.
Hi, good morning, Chairman Stokes and members of the committee. My name is Julia Roche, and I am the Legislative Affairs Director with the Baltimore City Health Department. Today, we have the Commissioner of Health, Dr. Emanuga, and our Assistant Commissioner of the Bureau of School Health, Francine Childs, to my left. And we have a presentation that I will do my best to figure out how to share. And I think I got it. There we go.
Okay. Good morning, Mr. Chair, honorable council members. On behalf of the Health Department, I'm going to go through our school health program and try to break it down so that we are all kind of on the same page as to what we're trying to learn from this informational hearing.
Before you start, real quick, I just want to be clear that this hearing is about health clinics. So if you have any additional questions, you can present them after we finish the hearing. Thank you.
Thank you. So if we go to the next slide, this just gives you an overview of the fact that the Health Department is the provider of record for school health services in the city of Baltimore. We staff both the school health suites and the school-based health centers. And I'm going to try to distinguish that because I noticed from a lot of the conversation today, we seem to be using those terms interchangeably, and they're very different. And it's important for us to understand that. We serve over 75,000 schools in the city, and this between us and our partners, City School, we're really happy that they're here today. We're able to serve about 159 schools. So like I said, we have the school health suites and the school-based health centers. And the way I always explain it is a school health suite is what everyone calls the school nurse. You fall in the playground, you bump your knee, you bruise your elbow, you go to the school nurse. That's the school health suite. A school-based health center is basically like a primary care clinic you stick in a school. It's very similar to where any of us goes for our primary health care. It's a clinic that just happens to be in a school. Students enroll, they have a primary care provider, they get many of the services that you would get or you would take your child to get in a pediatrician's office. And so these school-based health centers are considered an enhancement of the school health suites, which is why we don't have a health suite and a school-based health center in the same school. If we're going to have a school-based health center, we enhance the school health suite, and that way it becomes a school-based health center that does both services. And so if you look at the services that we provide in these health suites, we care for acute illness. Like I said, these are basically the school nurse, CPR, medication administration, health screenings. Many of the staff in the schools help with IEPs, student support teams, any communicable disease outbreaks or surveillance. You know, there's this outbreak in the school or that outbreak. This is where the school nurse comes in. And goes with health appraisals, nursing plans for students who are on IEPs or 504s. They also help with the support teams and the student and parent advocacy teams. Now, if you go to the schools that have a school-based health center, they provide everything that I've listed. And then in addition, students are able to come into those health centers to get an annual health maintenance. So basically, it's time for your physical. You can get it in a school-based health center. You play a sport in school, you need a sports physical. You can get that. Your immunizations aren't up to date. You can get that. Referrals to other specialty services, behavioral health, health education, some basic labs, reproductive health, and case management. The centers that provide these enhanced services are considered school-based health centers. Those health centers are staffed, like I said, similar to a primary care office. There will be an independently licensed provider. In most of our school-based health centers, that will be a nurse practitioner. Having said that, you might find one or two of our centers where there's a physician occasionally, but as you can understand, to staff a school-based health center with a physician full-time is not an endeavor that either us or our partner city schools could easily afford. So usually there's a nurse practitioner, there's a medical office assistant, and then there's a school nurse. Just in terms of the history, the school-based health center program in Baltimore City started back in 1985, and what was hoped at that time was to develop a center where we could provide comprehensive care to students who were in school. Recognizing that there were already traditional health suites, and this was an enhancement, like I've said before, of those health suites. And so there are currently 13 of these clinics. I'm going to focus now on the school-based health centers. These clinics, there are about 13 of them across the city. 4 are operated by the health department, and the other 8 of them are operated by Baltimore medical systems. And I think it's important for us to really understand how valuable what BMS is doing is for the city, because as an FQHC, they are a larger provider of care. And so what happens when the students in these school-based health centers see a provider in a BMS school-based health center, they are also part of the BMS health system, which means that even beyond when the school is open, they still have access to their same providers. And so, you know, I'm taking a little time to talk about this because I've always said, and I'll say it again, this is a model that is very valuable to the city and a model that we really want to encourage. In other words, having our federally qualified health centers be partners in this process. Our partners, the city schools, are doing a whole lot to support us, and we're doing our best to work with them, but there's a limit to the scope of what we can provide without outside providers being a part of it. And then lastly, we have one school-based health center that's operated by Johns Hopkins. And so the locations, our partners at city schools have already named these, so I'm not going to go through the list. We have some in elementary and middle schools, some in high schools, and then middle high, and then the others in the high schools, and that's the distribution. The next slide, if you look at it, it just gives you a pictorial view of how these school-based health centers are spread across the city in these different cadres. This next slide talks about the sponsors and then the enrollment. So like I said, a school-based health center is a clinic. In other words, the same way you would register with your primary care to become a patient is how students register in the school-based health center. When there's a school-based health center in a school, it doesn't automatically mean that if a child is ill, they can come down to the health center. Their parent does have to enroll them for primary care as they would in any other pediatric office. And so this slide is important for us to have an understanding of the number of students in the schools where we have these centers located, whether they're operated by BCHD, Hopkins, or BMS. There's a total of 10,000 students roughly that are enrolled in those schools, not at the school health center. Of the number of students enrolled in the school, about half of them, 50%, about 5,000, are actually enrolled in the school-based health center as patients. Of the ones who are enrolled, there's another 1,700 who actually use the centers. So again, it's important for us to understand the proportion of students who are choosing to enroll, or rather their parents are choosing to enroll, and after enrolling are choosing to use it. Now, school-based health centers were recommended as a model of care back, in the early 2000s because it was recognized that there are always going to be a proportion of students for whom primary care outside of school is burdensome, not just to the student who has to miss school days, but to the parent who has to take time off work. And if you have a job that doesn't have paid time off, you will literally have to choose between your pay and your ability to take your child for something that may even be health maintenance, and the child isn't even ill. And so we know that not everybody in the school is going to use it, but we do want to make sure that we're touching the students for whom this is particularly burdensome for them or for their families.
And Dr. Emanuga, before you move forward from this slide, can you speak to, because while these are valuable data, there's a lot of confounders here with regard to engagement, with regard to connection to the parents at the beginning of the school year. Can you speak to some of those confounders? I want to make sure that we have a proper understanding of the confounders for these data.
Thank you, Councilwoman, and that's a really great question. I'm going to go back a little bit to about 8 or 9 years ago when I was a medical director for school health. We had a program, a phenomenal program, that was Vision for Baltimore. It was a program that was in our schools where we had partnered with Johns Hopkins University and Warby Parker, the designer frame glasses provider, to provide glasses to students in schools. Every student who was able to register for the program could get 2 pairs of glasses, one that they could take home and one that they would leave in school so that if they forgot it, they would always have something. It sounds amazing, doesn't it? And yet, we couldn't get parents to sign on to this program. It looked like a no-brainer for us. Who wouldn't choose 2 free pairs of glasses, a free eye exam? You didn't even have to come to school to take your child there. You just had to give us permission. It was a real struggle to get parents to give us permission to have their kids examined in school and given glasses because they were skeptical. For some people, they thought it was too good to be true.
Yep.
For some people, it was a trust issue. I tell this story because I see this in healthcare all the time. And part of that is reflected as what you see here. Yes, part of it is it's who really needs the services that's here right now. But there's always going to be a proportion of people who do need it, but for whatever reason, they just don't have enough trust, confidence, relationship, whatever it is, to be able to uptake those services. And so the community engagement piece is really important. The people who partner with these programs is extremely important. How they're perceived by the surrounding communities and homes is really important. But all this feeds into the difference in numbers that you see.
And that's why it's so important, just to highlight what Dr. Pate was saying, to have people in the schools that look like you, that they can see, because these numbers, they aren't surprising to me, but I want to make sure that when we're talking about the feasibility and the functionality of school-based health centers and school health suites, we're providing the full picture of like what we have to do to include everyone in that conversation, because even some of our hospitals are having major issues with access, provider access, whether it be community report, whatever. They're having those same issues as well. So I don't want, I definitely appreciate and value this data, but I don't want it to be necessarily a deterrent or a hindrance of us kind of really leaning into how we can integrate this across the city. So thank you.
So Doc, real quick, I have a question. I'm looking at your total enrollment and your total clinic enrollment. School enrollment is 42, I'm just using the health department. Your total clinic enrollment is like 1,100. Total clinic users are only 389.
So those are users, so not the visits. You can see the visits are more.
Right.
So of the students who are enrolled, who's actually coming down to the clinic. Now remember, it's a clinic. And so people will come when they feel they have a need. Now there's a proportion that's health maintenance, I understand that. But these are the people who are using the clinic regularly. They're coming downstairs to do something or the other. Correct.
Thank you. Councilman Torrance, you have a question?
Oh, no, sir. I have a committee request to take a deeper dive into the numbers and unpack it. So I would like to know which exact schools we're discussing in terms of these enrollments by provider. Also would like the attendance data for each school as well from the last 3 school years as well. Because what I'm seeing is, I see the JHU, I think about KIPP because of the high enrollment numbers, and I think about KIPP being a citywide program. So because we have school choice, a number of young people that go to schools that have citywide offerings, the parents may not have the time to travel to and from a doctor's. So I'm just thinking strategically, what does this look like school by school? So as our committee requests, I would like to see which schools are by provider as well as the attendance data for the last 3 school years for each school.
Thank you. You want to finish your presentation? Oh, I'm sorry. Councilman Bullard has a question. So.
No, it's just really a quick follow-up to what Councilmember Torrance mentioned. I think the concern that some of us have is also looking at, it's one of the chairman's favorite words, equity, right? So looking at the students who are being served at that optimal level and making sure that there aren't gaps in service to the point that Councilman Torrance is making. So I know some of that will come out in the presentation, but definitely want to make sure we get that addressed. Thank you.
So the last thing I'll say, because our last slide is just questions, which I want to go back to what I said originally. We have to have the right partners for these programs to be successful. And Councilman Bullock did say at the beginning, cost is an issue, and you were right, it is. The American Journal of Preventative Medicine, about 7 or 8 years ago, conducted a study on economic evaluation of school-based health centers. And it came out saying what we all know, that where there are school-based health centers in a society or in an area, there are improved health outcomes, there are improved educational outcomes. There are dollars saved, like literal dollars and cents saved from Medicare, Medicaid, and other third-party payers. There are dollars saved per visit. There are less emergency room visits. So we know all these benefits. But in terms of the cost, that economic evaluation also showed that the cost of operating a school-based health center, the costs are split into the startup costs, as you can imagine, is very broad depending on where you're starting, and then the operational costs. But those operational costs run from about $16,000 to $17,000 a year per center, all the way up to over $600,000 a year, depending on what you're providing. But so I say this to say, it varies. It's very broad. It really depends on what you're doing and what you're not doing, but the costs are not zero. And the partnership is important. I just want us all to remember that and to underscore why the way forward is a partnership if this is a way that we want to go as a city. Thank you.
Definitely. Thank you, Dr. Emanuga. And I remember that study pretty vividly. The 600, I just want to again caveat, the 600,000, the 600,000 mark was a pretty large health center. I believe the average costs were around about 32, if I'm not mistaken. I got to look back and cite the data, but it was mid-level. It wasn't some of the higher numbers that we're seeing across the city. And I think, when you talk about school health suites versus like school-based health centers, I believe that there is such an opportunity for integration where we will see that cost reduction once we begin to kind of align services, align teams to make something like one operational perspective. And that's why I'm so happy that Dr. Connor is here, because I believe that, she really is onto something with that model. So.
Thank you for the presentation. Dr. Kate Connor will present a presentation of Rails Health Center at KIPP, Baltimore.
Certainly, thank you so much. I am just going to try to share my slides here. Apologies. I'm having some trouble with the permissions to share this. I don't know if we're able to otherwise do that. I can start speaking perhaps while we're getting that going. But I would just say good morning. Thank you for the opportunity to address you today. My name is Kate Connor. I am a pediatrician and assistant professor of pediatrics at Johns Hopkins University School of Medicine, where I am the medical director of the Rails Center for the Integration of Health and Education. I also serve as core faculty in the Johns Hopkins Center for School Health. At the state level, I chair the Council on the Advancement for School-Based Health Centers and sit on the National American Academy of Pediatrics Council on School Health. I'm thrilled that we've had such a wonderful overview of school-based health centers today because I think it is really critically important to understand the breadth of school-based health center services that can be offered and available. I was asked to specifically speak about the Rail Center model, thank you so much, which I will do today. The Rail Center was founded in 2014 as an opportunity to address the shared drivers of health and educational inequities for Baltimore students through school-based youth health and wellness programs. Thank you. Oh, okay. All right. I'll begin by just addressing the discussion of funding because I think that when we think about funding, we need to also think about the number of full-time equivalent staff services that are being made available. And also to think about the fact that in some instances, we're talking about funding just for a school-based health center operation versus funding for a full school-wide health program. And so understanding those components is a critical piece of understanding funding. I will mention that our school-based health center and full school-wide wellness program, which I'll talk about in a moment, was initially funded almost entirely by a philanthropic gift from the Rails Foundation. Over the years, philanthropic partners have been wonderful supports for our work and have desired to primarily focus on specific innovative programs, evaluation of our programs, as well as maybe startup or capital costs, and have consistently expressed that sustained operational public dollars are needed for school-based health centers, and we've sort of, as you can see here, diversified our portfolio substantially to have funding for our school-based health center. Now, this represents not just our school-based health center, but our entire school health and wellness program. But our primary funders at this point are Johns Hopkins Department of Pediatrics, as well as the Maryland Department of Health's school-based health center program grants, and a grant from the Consortium for Coordinated Community Supports as well. You can see that clinical billing revenue is a very small proportion of our overall costs. You see that in orange. And that is, there are a variety of reasons for that. School-based health centers are able to bill Medicaid, and Dr. Wormser will likely talk about some of the state level Medicaid regulations that allow us to do that in a really effective way. And there are many barriers to the amount of reimbursement that school-based health centers receive, the infrastructure needed to bill and get reimbursed effectively, and the amount of care that we provide that is not reimbursable. So the councilperson referenced some like administrative claiming or claims for kids who are getting school nursing services through IEPs. When those things occur, they collect at the district level under special education, and much of what school nurses are doing is actually not funded by that mechanism, although some of it is. School-based health centers do not bill in that way. We bill directly to Medicaid. And since we serve children who may be uninsured or underinsured, it's really important to think about the need for sustainable operational dollars that does not just come from clinical revenue. So I'll begin by talking about our coordinated model of school health and wellness. And this model features a comprehensive school-based health center, which is embedded in a program that also provides universal school-wide wellness services and population health-focused school nursing. I think it is important, as Dr. Emanuga pointed out, to distinguish between these services. We believe in the power of operating all three and in integrating them, and you can absolutely have a school-based health center without that. You can have school nursing without a school-based health center. Those are all distinct functions. So I'll do my best to call them out as we go through specifically. Our partners in this work, as you heard mentioned earlier, are KIPP Baltimore. We have been located there inside the school since 2015, which was before their move to their new and current building. They're home to 2 public charter schools co-located on the same campus in the Walbrook neighborhood of West Baltimore. I think it's important to point out that students enrolled at KIPP Baltimore come from all areas of the city, but predominantly the 3 zip codes surrounding the current location of the school in Walbrook. Health indicators in these zip codes are in many instances worse than those for the city on average, and the majority of students at KIPP do live in areas of concentrated poverty throughout the city, but again, particularly in those neighborhoods. This year, they anticipate enrolling 1,380 students in grades pre-K through 8, although their numbers have been as high as more than 1,600 during the course of our partnership. The framework for our project is the CDC's whole school, whole community, whole child model for addressing school health. I won't go into detail about this here, but I'll just say that there has been a lot of work done on how we can have this student-focused approach that really emphasizes the types of community partnerships that we've been talking about here today, and those opportunities to support students within schools. So as I mentioned, we have 3 main service delivery lines in our program: universal school-wide wellness programming, school health services, and the school-based health center. Since we're primarily talking about school-based health centers here today, I'm just going to briefly touch on the other programs. Our wellness program has worked over the years in many areas, ranging from health education to recess redesign to staff wellness. But the primary area of focus based on school priorities has been social emotional learning and school culture and climate. Our wellness program director has partnered with school leaders to create a culturally affirming, to adapt an existing social emotional learning structure to be culturally affirming and responsive to the school's focus on social justice. And we have seen improvements in key teacher reported culture and climate metrics as a result of that work. The health center is the physical home of both school nursing and the school-based health center. They are co-located. That is not always the case for school nursing and school-based health centers, but we find that this improves efficiency of referrals from the school nurse to the school-based health center. We know that school nursing is the foundation of any school health program, and so we prioritize having 2 full-time school nurses and really emphasize the population health approach, which includes screening, care coordination, and case management, really working to identify kids with health conditions that may impact learning. And our school-based health center is staffed full-time by a medical office coordinator and a pediatric nurse practitioner. I am the pediatrician medical director, and I do see patients there 1 day a week as well. We are adding, as Dr. Pate mentioned, a community health worker in the coming school year with support from the Consortium for Coordinated Community Supports. We serve students in the full range of primary and preventive care. I will mention that in Maryland, in general, school-based health centers are not designed to be the primary care provider for students. Under Medicaid, they are still meant to have a community-based primary care provider. So we consider ourselves sort of an extension of the medical home into the community. We work hard to collaborate with primary care providers in the community while also understanding that those access barriers to traditional primary care exist and are important and may affect different families in different ways. So we need to be there to provide those supports. We ensure clinician coverage 5 days a week during the school year, which allows us to really have this population health focus where we look for kids to try to enroll them in the school-based health center and provide them with care and services. I will mention while I'm thinking of it here that in terms of the request for data about school-based health center utilization and attendance at the schools, I will note that some of these utilization data are actually still showing the impacts of the pandemic. These are from last school year, and many school-based health centers did have a decline in enrollment and utilization over the pandemic because of the lack of opportunity to get physically in front of patients and kids. So many of us are still sort of rebounding in terms of numbers from those areas. And certainly the pandemic also had independent effects on school attendance. So just some important context for that important data request. We have special programs that are focused on asthma, vision, cardiometabolic health, and mental and behavioral health. And we have expanded service offerings that include summer hours, group education. We offer vaccines, routine vaccines for any city schools student in a partnership with city schools. Family planning and reproductive health services are extended to KIPP alum through age 22, and we offer COVID vaccination for any community member. One of the critical parts of our work is creating and utilizing data systems to identify our program's impact. And I'm just going to quickly highlight some of the key impacts over the years. It is important to know that parsing out these impacts can be difficult because there are so many other things that impact students' school attendance, their asthma, et cetera. And so these data on those issues need to be thoughtfully interpreted. In terms of health impact, we have seen improved asthma control, increased classroom physical activity, decreased emergency department utilization, and decreased healthcare cost. In terms of educational impact, importantly, we have seen significant decreases in chronic absenteeism among our students, particularly those with chronic conditions like asthma and ADHD. I will point out that these data are pre-pandemic. Certainly the pandemic has impacted school attendance in a variety of ways that school-based health centers can help to support. We've also seen improved classroom behavior in relationship to some of our vision programming. And importantly, we've just published a paper demonstrating improved growth on standardized assessments, the measures of academic progress testing in both math and reading for school-based health center enrolled students compared to those who were not enrolled. This really does examine the issue that was raised around whether or not kids with the greatest need are being served, because we also found in this evaluation that students enrolled in our school-based health center were more likely to have chronic health conditions, more likely to be chronically absent from school before they enrolled in the school-based health center, and more likely to have lower scores on their MAP test before they enrolled in the school-based health center. As Dr. Emanuga mentioned, there have been several economic analyses. This net social benefit analysis showed savings associated specifically with our asthma programs. So we have several important lessons that we've learned over our nearly 10 years of doing this work that I think are relevant to this conversation. And I want to certainly thank our colleagues at City Schools, the health department, who Francine really helped us to figure out what is school health and how to do it when we opened, and to our partners at the state, the Maryland Department of Health School-Based Health Center program in learning so much about school health. One essential component is that school leader engagement is essential, and that's not just at the school level, although that is critically important, but also at the district level. Dr. Pate and everyone at City Schools have been amazing partners in our work, and they know their students best and their school's needs and where school-based health center resources can be best spent. As has been discussed here, collaboration, integration, and trust are key, and it takes time to build those relationships, and it really requires being there for the school and community. I will reinforce that adequate school nursing capacity is the critical foundation for school-based health center success. It's not an absolute necessity, but it is certainly essential to successful integration. I will note that the American Academy of Pediatrics and the National Association of School Nurses both recommend that there should be at least one registered nurse in every school. For us, work across the spectrum, including wellness and school health services, is important and has increased the power of our model because we operate all of those three services. That's not the case for every program, but it is for ours. I think as an academic health center, Dr. Emanuga pointed out some really important benefits of sponsorship through a federally qualified health center, which nationally is the largest group of sponsoring organizations for school-based health centers. As an academic health center, one of the benefits is that we are able to leverage trainees to support pipeline efforts, as well as our program's capacity. I think one really critical thing to point out is that sustainable operating funds are essential. Historically, school-based health center funding and school health services funding have become sort of inappropriately or unintentionally intertwined because we need both in order to have the full program be successful. Really, they are separate funding. School-based health center funding, most often operational dollars at this point, are coming from the Maryland Department of Health. and school health services funding comes separately, either by way of the health department, city schools, or grants and other funding. But sustainable funds are critical for innovation and expansion and pushing the needle for kids, because if those of us who are working to administer school-based health centers spend all of our time looking for dollars in different places, we can't focus on really continuing to support our program and its operations.
And Dr. Connor, really quickly, thank you for bringing that to the forefront. Baltimore City Public Schools, are Kerwin dollars able to be used for these types of issues that Dr. Connor is raising, such as construction, onboarding costs, other operational costs?
So the Kerwin, under the blueprint, the concentrations of poverty dollars, there are funds that are able to be used as health suite costs. There was also a provision under the blueprint that that each county in the state has to continue the same level of support they provided for health services prior to the blueprint. So there's that level.
So it's a both and. It sounds like a both and. Great. I'd love to see more of that connection as we talk about that expansion of school-based health centers, how we can utilize that funding for some of the issues that Dr. Connor's raising.
Well, and there are, so that funding explicitly is more designated towards school health services. We, for example, have funding through a concentration of poverty grant to KIP to support one of our school nurses. And under the blueprint, there was also funding designated to the Maryland State School-Based Health Center program for operational grants, which Dr. Wormser will talk about.
So real quick.
Yeah.
Colleagues, let them go do their presentation, and we'll have the questions afterwards. Thank you.
Sure. Perfect transition, because I was just going to talk about opportunities for dissemination. I'll first say that, many of our programs, we were founded to really create, implement, and rigorously evaluate comprehensive integrated school health and wellness programs. And so we are thrilled to talk with folks who are interested in dissemination of all or part of our program. Parts of our programs were designed to be exportable to folks with varying resources and capacity, and we have toolkits and other opportunities to share with folks. The blueprint, as we mentioned, provides additional funding, as does the Consortium for Coordinated Community Supports. For example, those funds are allowing us to expand youth suicide prevention intervention to 6 city schools, so beyond KIP, and additionally developing that CHW program that we talked about previously. I think that overall, while these new sources of funding are available, as we discussed, school health funding remains limited on its whole, and a thoughtful and systematic approach to leveraging these newly available resources to expand school-based health center access to city schools students is needed to ensure that the resources are used as efficiently as possible and to create the greatest impact. City schools, the health department, and the Maryland School-Based Health Center program are the first and best resource in this work. And I have a list of additional organizations that have been doing work in this area for many years and can provide information and thought partnership. Many of them, but not all, are represented here today. One to call out is the Maryland Assembly on School-Based Healthcare. Thank you so much for the opportunity to share this information with you today. This is one model of integrated school health that has been shown to have an impact in city schools, and we really look forward to continued discussion about expanding the reach of school-based health centers citywide.
Thank you for the presentation. Councilman Torrance?
Thank you. You did answer the question related to funding sources. I want to go explicitly to city schools, especially given that city schools receive, I believe, over $700 million from the federal government in terms of opera, similar to city government. Why wasn't it prioritized to build out more health centers with that given influx of funding?
So with those resources that we've, I think, done a really excellent job of spending and making sure that we're using them on there was a lot of course, investments we need to make to recover from the pandemic for young people. So there was a lot of academic investments we made to address the learning gaps that we had. There was a lot of facilities investments we made in terms of air quality. And we also did some renovations to existing health suites. So health suites themselves are not in the condition they need to be. And so we did renovations to health suites as well as our science labs, as well as, again, bathrooms in our buildings, which were not the condition they should be. So that, as well as most money in city schools, has been spent multiple ways till Friday in terms of the ways that we could spend it. And we have to figure out the way to prioritize it to meet the greatest need. And so I think we've done that. We've closed out 23 of the 29 grants and spent 99.7% of them, and we're on track to spend the rest. We do have more health suites in the queue that we're doing renovations to get those to a level that meets the needs of our school-based health staff.
As a committee request, I would like to see which sources of funding were spent on upgrading health suites as well as health centers. The reason why I just want to make sure that, and this is for the public's consumption, while we're making these large investments, those one-time funds, it is important that we look at where those investments went, particularly in school communities that have issues with attendance. I say this because I know that KIPP has significant increases in attendance when they had access to their health department. I say that because I have a school at Douglas High School where there's a significant attendance issue. It's something I worry about as they're moving to Northwestern, but also I serve historically redline communities in West Baltimore. We have no hospitals in my district. We are in a primary care desert. Finally, we are moving forward with moving the women's facility to BCCC so that we can provide and expand access to women's reproductive health. But also, we now have partnerships at the Village Mondawmin where we're bringing in primary care for our older adults, as well as primary and specialty care for other populations of community members. However, for Douglas High School, we see that even from the 2022 assessment, that there are a lot of kids who have access to these, that need access, but also have the indicators that we need to bring down in our community. So I just want to make sure that while I look at where the investments go, but also make sure the public understands why the investments were to other schools, but also looking to ways that we can build off of that to look at where we can invest in other schools where we have attendance issues as well.
Could I add a quick response to that? Is that okay? Thank you. I would just add that I think the ESSER funding in particular, because it was not intended to be sustainable, there are some places that have used ESSER funding in different ways to make investment in school health personnel that they're now losing. So I think that the ESSER funding as a school-based health center funding opportunity might not have been as sustainable as we would have liked. And there are opportunities through the blueprint under the community schools components and the concentration of poverty grant components to physically build out school-based health centers as you're referencing through the IEC process. And so I think finding those more sustainable sources of funding will be important ongoing in terms of building out the school-based health center program.
We're on the same page. I think two parts. One is one-time ESSER funding, in addition to what we had in the blueprint, could have been an opportunity looking at school communities that were desperately regionally isolated, especially in South Baltimore. For a particular, we could have made strategic investments and work with the health department on addressing these. Because I think about the high asthma rates, the heat island that we're facing in terms of young people in other portions of the city. I think that there were opportunities that we had we all been in the room together to make these decisions, to have built off even our ARPA dollars to build those centers out too. Because I see this as two things. We serve communities that are in desperate need of health access. I say that as someone who just recently lost their grandmother, right? Whose only access was through Johns Hopkins in East Baltimore. But that same access that she would have had she stayed in East Baltimore to memory loss care that I now have in West Baltimore, it was different because of the zip codes, right? And that was something that we had to address with zip codes for senior. So I think that we need to have a more cohesive approach to it, because we could have added to it in terms of adding that access. Because I think about young men and women who are in Northwest Baltimore who don't have access to primary care as well. It is, to me, a missed opportunity, but it is a way to move forward to figure out how we can do this together.
And I would just say, I think it's important to really remember all the partners in the room in terms of how to make these investments because, in city schools, and I appreciated Councilwoman Porter acknowledging that, health centers is not something that city schools can really, has the structure to take on. And so really thinking about all our partners because as we've received the ESSER dollars to respond to a pandemic, as we received increase in blueprint funding, we have multiple gaps in the academic programming that students have access to, which also has impact on attendance. We did a lot of work with attendance, doing attendance work in terms of going out and visiting families to make sure that we got back to school, to create tutoring programs to catch students up so that they feel successful at school. All these aspects of a student's life are really important to make them sure they feel engaged in school, they're connected to school, and health is one of those. And we really appreciate the partnerships from the health department and from and our partners at Rails to really make sure that we're addressing all the needs of students. And as a school system, we need support to help do that in some of the areas that we are less experienced in.
Councilman Bullock.
Thank you, Mr. Chair. I do appreciate the distinction that was made earlier between the health centers and health suites. So thank you for making that clear to everyone. And then also thinking about the range of funding needed, think about the high and the low. And then as Councilman Porter mentioned, sort of the average of what we can expect. But I'm also following up on something that Councilman Torrance was queuing in on. I'm thinking about some of the gaps, some of the disparities, and then one of the questions and answers earlier. So when we're talking about staffing and the decisions being made, a lot of that will seem to be related to the utilization of the private nurses. Can you talk about if that captures all the need that we have? I think that's a useful benchmark in terms of the utilization of those private nurses, but then also, are we capturing all the need in terms of the health of our student population? I'm just curious how you look at that.
I would say the primary way that we capture what the students' health needs are is from information from the family. At the beginning of the school year, we ask all families to let us know what their children's health conditions are, and through utilization of that school health suite. So as well as other ancillary programs. So I operate the CHIP program for a city school. So when we see multiple kids utilizing more CHIP days, that's a cue to us to then connect them to the city's asthma program. So we'll reach out to the health department and do a referral to the asthma program if we see Mikey has missed several days and requested CHIP because his asthma is uncontrolled.
I will say, and I want to be sensitive to even some of my colleagues, one of the things that we deal with, and I'll use my district as an example, we may have, for instance, outside of health, we'll have a majority of some of the vacant houses, some of the dumping, and even though that may be the case, we don't always have the same number of 301 requests. And oftentimes, the way that our city works is sometimes it's a complaint-driven process, and the squeaky wheel gets the oil. So part of the way I'm asking this question is it the squeaky wheel that's getting the oil, or are we going past the squeaky wheel and also thinking about where we're not touching and managing folks' health?
I would say in a lot of cases, we try to cast the broad net and then see where we have the uptick. I'll just use immunizations for an example. We made an extraordinary effort to go to specific communities where we had higher numbers of kids out of compliance for immunizations. We would go and 6 kids would have a consent form for immunizations, whereas though I've come with immunizations to immunize 100 kids. So a lot of times it is, we put the resource out there, but the resource isn't utilized.
And I guess one other thing I would add is the point you made earlier about when we are placing some of the resources we have, like the university partnerships, really looking at the health profile of the students in those schools to make sure the students who have the highest need are getting some of those additional resources. So though, to your point, those schools where we had a lot of private duty nurses, making sure that we had a university partner to provide services so that the students who really need those additional supports are getting the quality care in the health center. We would love to go, we always are trying to figure out ways to go further beyond that, and working with partners and developing partnerships to do that. And the immunizations is a great example where we've done that.
No, thank you for that. I know it's not easy work, so trying to match all this, but I appreciate you walking us through it.
I just have a question. I know you talked about Johnson Square, Dr. Bernard Harris, and Harvard Heights not having the numbers. equity means a lot to me. And just because they don't have the numbers, I'm sure you still have kids in them schools that have problems with asthma. Why are we not still addressing it or have someone to go in them schools and make sure we following up with those young people, even if it's less than some of the other schools? But you can't tell me Hopkins got a footprint in East Baltimore, and you got 3 schools that totally been ignored. That should have been a priority if they only got 5 people, if they only got 3 students. That should have been a priority from the beginning. That's 3 of the schools I started an asthma program with. Now we got Hopkins do a footprint, and we say, oh, well, their number's not high. But I'm sure some kids in them schools are still having asthma problems. I'm sure the parents don't understand what to look for asthma. So my commitment or asking you to do is we still need to have some resources in Dr. Bernard Harris, in Johnson Square, and Hartford Heights. I can't believe that is not a priority when Hopkins is 5 minutes away from all, or 10 minutes away from all those schools. It's really appalling that that's not a priority. To me, it just sounds like, well, you know, you don't have a whole lot of kids there, so we're gonna go to these other schools and monitor those kids there. That's real disturbing for me.
So can I just make sure we're not conflating 2 things? So the university partnerships was city schools' effort to go ahead and get health services in the 35 schools that we had ownership of. It was only 35 schools that we had from the health department that we needed to figure out how to staff at city schools. So we weren't starting with a base of all 151 schools. We were starting with a base of 35 schools. And those schools that you named, unfortunately, aren't in our 35 schools. But still, that's not to say that those schools don't still have access to school health services. So just because they aren't a Hopkins school through the university partnership, they're still receiving school health services through the health department. And within the health department, there are still other opportunities and partners that they branch out to in order to make sure that those kids in those schools do still have access to school health services.
Well, I'm glad my colleague talked about the data, because I want to see it too. Because that's a great answer, but to me, there still should be some emphasis on those schools that's close to Hopkins, period. I don't care who's doing it. The way it's presented is like, okay, well, their numbers are not that high. So when you use Hopkins footprint, the first thing you're gonna think about is Hartford Heights, Johnson Square, and Dr. Bernard Harris, period. If you can present it to us, but if you go talk to a family and ask them about, and present to them that those schools use it as a Hopkins footprint and those schools really don't have the same resources as other schools, it comes confusing for parents. Then they come frustrated. For me, I wanna know, see the data to see why still that Hopkins is around the corner, 10 minutes away, 5 minutes away, 3 minutes away, footprint all over East Baltimore, development, everything, and you said.
So Hartford Heights has a school-based health center operated by Baltimore Medical Systems, just so we're clear.
Okay.
I would just add, I think the baseline goal of having a nurse in every school across the city in order to provide the required level of school health services is, I certainly would not dare to speak for my partners at City Schools. And my understanding of that work is that this has been designed to be an expansion to try to really push towards that goal of having a school nurse in every school. And since there are so many different folks who are involved in that operation, including the health department, City Schools, BMS, and ourselves, that does happen in sort of different ways depending on those different pockets. I will say I've seen such a dramatic increase in the support for school nursing and school-based health centers in the past 10 years that I've been doing this work. That doesn't mean there aren't more schools that absolutely need it, and thinking about the ways to distribute those resources efficiently and creatively and systematically is really important.
Thank you. Councilman Torrance?
I just have a data request because long time ago, this used to be the bane of my existence with school health. I would like to know by count, the number of RNs in every school, whether across provider, the RNs who are supervising LPNs at our individual schools, because I know that some schools can't have a full-time nurse, so that RN is supervising multiple RNs and the CNAs. So I just want to know what the actual staffing level is to understand like the need. I think that would be helpful for everyone here to know where we are in terms of the provider, as well as how many RNs we have, if the RN is supervising either CNA or LPN, depending on the school. And then the other piece is, who are we paying in terms of, because there's a gap. There's truly a gap, I'm not gonna lie, in terms of who are we paying as an external vendor to provide support there too, because that is another cost that we haven't really factored into it. I think that'd be helpful for us because that helps us with being a partner too, to see how we can support you in terms of funding, because I'm just being realistic with you. A nurse can make at least $4,000 a week in a travel contract rather than sitting in a school building. So,
And you're totally right. I think this is a great opportunity. The 20 nurses that they mentioned at the beginning will be moving over to full-time city schools employees. So that can be, like you were saying, a barometer of like the funding level that's needed.
So I appreciate this question, and it's an area where we need support. And so I'll start for city schools, and then I'm going to turn over to Dr. Imanuga. So of the 35 health suites that we run, we have RNs in all of them. The 15 schools that are school-based health suites, that are with the university partners, rather, they are nursing students, but they're RNs in those. And then the other ones, currently, to Councilwoman Porter's point, currently we use those through contract nurses, but we have a vacancy open now, and we're hoping to fill all 20 of those remaining with RNs that would be employees of city schools. The other 114 health suites and centers are under the purview of BCHD, so I'll turn it over to Dr. Imanuga on those.
So real quick, I would like to get more information on that, but still think poor black neighborhoods, poor black schools always get shortchanged. There's always something different in their schools. And you got a hospital like Hopkins sitting up on a hill, and you're talking about Oliver, Johnson Square, Hartford Heights, Broadway East, poor black neighborhoods, and there's always a different numbers in terms of those poor black schools in Baltimore City. So I just wanted to make that comment. Thank you for the presentation. We now will go to Dr. Benjamin Wormser, who will do a presentation from the Bureau of Mental Health, Maternal and Child Health, Maryland Department of Health. But Dr. Wormser, if you have any staff here, could you go ahead and introduce them before you start? Thank you.
I'm sorry. Okay.
I said, can you introduce any of your staff that you have with you?
Hi, my name is Samuel Paul. I'm staff for Dr. Wormser here from the Office of Governmental Affairs.
Chair Stokes, Councilwoman Porter, thank you very much for the invitation to come speak with you all today about the Maryland School-Based Health Center program. My name is Ben Wormser. I'm the medical director of the Maternal and Child Health Bureau at Maryland Department of Health. I'm also a general pediatrician, and I've had the privilege to work in 2 Baltimore City school-based health centers before I joined the state. Slides went down there. Thank you. Unfortunately, my next slide was a visual one, so I had to wait for that to come back up. So the Maryland School-Based Health Center program currently runs 87 school-based health centers in 16 different jurisdictions across the state. There are 14 school-based health centers in Baltimore City. And if we go to the next slide, we show the representation. The red dots are the physical location of our school-based health centers. The yellow are the zip codes from which students that have had visits at those school-based health centers reside. So you can see that almost all of Baltimore City has coverage from our current school-based health centers. They're seeing students from across the city. Can we go to the next slide, please? This was already covered by Dr. Imanuga previously, but I just wanted to spend a little time really focusing on the definition of a school-based health center as it pertains to Maryland. We consider a school-based health center a clinic that is located in a school building or on a school campus. That's a must, and that provides comprehensive primary, acute, and preventive care services to students and other individuals who enroll in the school-based health center. Visually there, within the school, we have the school nurse represented in the red box, and then in the green box, separate from that, is the school-based health center, at which employs either a physician, a nurse practitioner, or a physician's assistant. They're able to provide a much more comprehensive care visit, diagnose illnesses, prescribe treatments, make referrals to subspecialists because of their scope of work. Next slide, please. In terms of what school-based health centers do, we have core services which are required of all of our school-based health centers, and those include primary and preventive health care, management of acute illness and injury, and then referrals to specialists and social services. If we go to the next slide, we also then have expanded services, which are the optional services that a school-based health center and their local community make a decision about what other services they want to add. So that will include behavioral health, oral health, health education programs, nutrition, childhood vaccines, and sexual and reproductive health care. Next slide. It is also a local decision about who the school-based health centers are going to serve. We do require that all school-based health centers serve the students in the school in which they reside, but then our school-based health centers, some of them have decided to also serve students from other schools who are brought to the school-based health center. Others will treat parents and guardians or siblings of students. And then others still will expand their encashment to school staff and other members of the community who are not otherwise associated with the school at all. Next slide. As was previously covered, patients must enroll in a school-based health center to be served there. A lot of our enrollment occurs at the beginning of the year. It's part of that big packet that gets sent home to all of the parents and guardians. But we are able to enroll a student even on the day of the visit if they have not previously enrolled and require care. Next slide. And then lastly, patients, an important part of this program is that, and one of the reasons that we provide grant funding is that patients are to be treated regardless of their insurance status by our school-based health centers. Almost 40% of students who received care at a school-based health center last year either did not have insurance or were underinsured. Next slide, please. I'm going to actually skip this slide because I think a lot of folks have touched on the value of a school-based health center, except to say that it brings healthcare to where students spend the majority of their day, and healthier students learn better. Next slide. Going back to our visual of what a school-based health center is, I now want to touch on the leadership organizational structure of school-based health centers. So every school-based health center in the state has both an administrative sponsoring organization and a clinical sponsoring organization. One organization can serve both roles, and in fact, the 4 sponsoring organizations in Baltimore City that have been mentioned previously, they all serve in both roles, but it can be split. And then the Maryland School-Based Health Center program within the Maryland Department of Health oversees all of the sponsoring organizations. Next slide. Just to go over some of these roles of the different sponsoring organizations, the administrative sponsoring organization is the one that holds the MOU with the school system that describes, what they're going to be providing in a school-based health center. They're responsible for adherence to all federal, state, and school system regulations. They may hire an administrative staff, especially if they are overseeing multiple school-based health centers and need just help with some of the administrative burden. And then this is the organization that applies to the state Maryland School-Based Health Center program for grant funding. Next slide. The clinical sponsoring organization really manages all of the clinical medical side of it. So they manage the electronic health record, they hire and oversee the clinical staff, they provide malpractice insurance to that staff, and then they also develop the clinical policies and guidelines through which they're going to actually deliver care. Next slide. We've talked a little bit about funding, and I just added that to our visual here as well. So there are green arrows depicting some of the sources of funding. So one of the biggest ones, as we saw in Dr. Connor's slides, is the arrow going from the Maryland School-Based Health Center program to the administrative sponsoring organization. Those are our annual school-based health center grants that go to our sponsoring organizations. Those administrative sponsoring organizations also often get other grant funding from either federal partners at HRSA or through local governments, nonprofits, a variety of funding sources there. And then our clinical sponsoring organizations, as was also touched on earlier, are able to bill insurance. They can bill private insurance and Maryland Medicaid. And they are able to bill Maryland Medicaid MCOs without having a contract with each specific MCO, which is it reduces the administrative burden a little bit. Councilmember Torrance, to sort of go back to a question you had asked earlier, we do ask that all reimbursements from billing insurers for care provided in a school-based health center goes back to supporting the school-based health center, the staff of the salaries, et cetera, rather than going to the third-party organization. So, yep. Next slide. Oh, I'm sorry. There was one more point on that slide. There is an arrow also coming from the school system to the school-based health centers. Often that is in the form of supporting facilities, new buildings, or renovations of existing school-based health center space. Now, I've been talking a lot about the Maryland School-Based Health Center program, and so I want to sort of explain that a little bit more. Technically, in the state of Maryland, you can open a clinic in a school. You can even call it a school-based health center and not join the Maryland School-Based Health Center program. There's nothing stopping you from doing that. But if we go to the next slide, the advantages of actually joining the Maryland School-Based Health Center program is that it makes you eligible for the state school-based health center funding. It gives you the opportunity to bill Medicaid as a self-referred provider, which is what I described earlier, where you don't need to have a separate contract with each MCO. And then it also brings you into the fold for all of the access to ongoing technical assistance and support from our state program. And the next slide, right here, the approval of a school-based health center is based on a school-based health center meeting minimum requirements that are described in the Maryland School-Based Health Center standards. A lot of what I've described in my previous slides come from the standards, and they're available on our program website, the first page on our website. If we go to the next slide. And so just to visually depict the sort of journey of opening a school-based health center, which can take several years because of all of the different components. We always recommend that you start by identifying local partners. Who's interested in serving this local community that you've identified has a need, who's already there, who has experience in this space. And then you conduct a local needs assessment. Coming to your question, Councilmember Bullock, you want to know, like, specifically, we want to know about our students, but also the surrounding community. What needs are there? What resources are already in existence? And of all of those optional services that you could provide, what's really going to meet the need of your community? Then you want to develop formal partnership agreements between all of those partners, build or renovate the school-based health center space and stock the equipment, develop administrative and clinical policies, and then the very last step is to apply to the Maryland School-Based Health Center program for approval to join the program, and that's making sure that you're meeting all of those requirements. And I'll acknowledge up front that that's a lot of work before you get to the state grant funding, and so we've been working to build out some resources to try to help support all of that work. We have what's called a planning and onboarding program. It's essentially a 12-month academy that walks you through all of these different steps in much more detail, and it's free to anyone who's interested in participating. We, in the past few fiscal years, have been able to provide school-based health center planning grants, which are grants specifically for conducting that needs assessment, buying equipment, renovating a space for schools that do not yet have an approved school-based health center. And then I just wanted to also call out that we do have other technical assistance partners like the Maryland Assembly on School-Based Healthcare, who can also provide a lot of support to organizations that are starting this. That last bullet there is the Maryland School-Based Health Center Program email address. This is one of the most frequently checked email inboxes in the state of Maryland. So I encourage anyone who is interested in or has questions to please contact us via that email address. All of these cases are so site-specific that it's really hard to provide general guidance, and it's much easier if we just have a conversation about your specific journey and try to help you out.
Thank you, Dr. Warmer. I had a quick question about just the evaluation criteria for school-based health centers. So you mentioned in one of your slides that any clinic can open up. They don't have to be necessarily in the school-based health center program. Is there a geographic kind of radius or location that you all use to evaluate whether a clinic is coming into a program or not? How do you prioritize that?
Thank you for that question. So you had referenced our 2022 statewide needs assessment for the school-based health center program. In that needs assessment, as I know you are already aware, there is a list of schools that we conducted our own sort of community-wide needs assessment that we sort of deem high risk based on healthcare access issues, educational performance, and healthcare needs. So that is a guide for local jurisdictions, but actually the location of a school will not be factored into the approval of a school-based health center. If you've gone through the work of putting a clinic in the school and meeting all of the requirements, the question comes down to, do you meet all of the requirements, not what specific community have you chosen to put the school-based health center in?
Sure. Thank you for that question. And now I'm going to turn back to Baltimore City Public Schools and Baltimore City Health Department. Have you all evaluated this list based on the school-based health clinics that you're renovating, operationalizing? This list that Dr. Warner's talking about from the school-based health centers assessment? No? Okay.
I'll turn over to Dr. Manuga. We don't run any of the health centers.
No. But
When you say evaluate, I'm trying to understand.
So what I'm trying to do is looking at looking at resource allocation. So if this particular agency kind of put out a list of high risk areas or high risk centers, I want to make sure that you all are kind of using that information. One, because there are limited resources, and number two, the catchment area by which these health centers are in. We want to make sure that we're having the most population going to one health center. And so we're not segmenting the population.
Right. So I think from our perspective, we don't have the capacity to operate any additional school-based health centers. Of the 12 we have at the moment, we operate only 4 of them.
Sure.
But in the event that a partner did come forward with a willingness to partner to operate one, then yes, that list would be valuable to us. But unfortunately, even though the list is in place, we just don't have the ability to take on an additional center.
Yes, ma'am, I understand that. I want to make sure, my apologies, let me rephrase my question. I want to make sure that if any of the 14 that are on your list are on Dr. Warmer's list. Okay, all right, thank you so much.
Councilman Bullock.
Oh, yes. Thank you, Mr. Chair. And again, I appreciate, you giving us some additional information. Just one quick point in terms of the state program. Obviously, there are a lot of benefits that are involved with it, but it's a lot of work. I would like you to answer it, but then also from the school and health department, why would an entity not join the program? I'm just curious. I mean, because obviously there's some grants associated with some work, but I'm just curious in terms of decision-making process.
That's a really good question. To my knowledge, there are none that currently operate as a school-based health center outside of the program. So this is a hypothetical, and I think we do have a list of requirements that a school-based health center must meet. They're mostly focused on the availability of certain laboratory tests, certain equipment that is fairly basic, and needing to be able to provide primary care, not just treating the child who's sick today, but also chronic disease management. So if you wanted to open a clinic that was only going to take care of kids who are acutely sick, you wouldn't meet the minimum requirements of a Maryland school-based health center program, school-based health center, and so you might choose to not pursue that approach. I think and then we also do require that you have in-person services. We haven't really talked much today, but many of our school-based health centers do provide telehealth also. But we do require that you are at least in person 8 hours a week. And there are some, telehealth only organizations that might not want to meet that requirement, and that could be another reason.
Got it. And then maybe one quick follow-up, because I know you mentioned resources, funding is key. With the grant process, I assume it's very competitive, but can you talk about how competitive that process may be?
Well, the state's been very lucky over the last few years with the blueprint funding that there was a significant increase in operational grant support for the Maryland School-Based Health Center program. And so it is not competitive in the sense that school-based health centers are fighting for dollars. I think that as more school-based health centers join the program, it likely will become that way, but right now we are able to standardize the funding formula so that it is based on various factors like the number of school-based health centers you're operating, how often they're open, are you providing just the primary care services, or are you also adding behavioral health, which means a new provider that is, now you're paying two salaries. So we try to match the funding level to the services that are being provided.
So you just anticipated the last question I was going to ask, and I think this is a broader question we need to have not only as a health system and society, but in terms of mental health and how that also connects with the day-to-day service to our students. Thank you.
Councilman Torrance.
Thank you, Mr. Chair. Thank you, Doctor. I'm actually looking at your list, and I have 3 schools on the list, all in the same community. William Barrett School, Connections, as well as Douglas High School. So for me, the logical location for Douglas being in the middle of all 3 makes the most sense. And I'm just going to bring this back home again. There's a need. I say this primarily because 2 parts. When I visit these schools, there are a high number of young people who have asthma, a high number of young people, which I just found out that the school is sustaining at Douglas, that have diabetes, right? These are all things that during returning back to school that probably complicated young people actually going back to school during COVID-19. So I just want to bring home the urgency and actually making sure that we can bring this center. Happy to dig down deep, roll up my sleeves to figure out how to do this, because that is a high need. It is one of the things that I did promise my community about bringing more healthcare to West Baltimore, and I think this is the next factor. We provided it for our seniors, we provided it for the University of Maryland, for other people in my community. Now it's time for young people and people who aren't insured to get access to. So I think that So as a committee request, I would like to have a meeting with the Baltimore City Health Department as well as city schools to discuss a project management in terms of bringing a provider through it, but also leaning on the experience of Rails. Would love if you guys can be present, because I do remember that it was a sole source at one time through the health department that Rails was entered into KIP. So I think that we need to learn from that prior experience so that we can figure out how to benefit and close the gap fast. I'm happy that a school board commissioner is here so that we can have the support of the board as well. I just want to end there because I think that this is a need. I'm willing to dig down deep, find funding for it, but I just can't allow us not leave this room without a way forward. Thank you.
Thank you, Councilman, but I think a meeting should include members of this committee also who want to be a part of the meeting.
More friends, the merrier.
Thank you. Any other questions from the committee?
And next is Mark Maloney.
Thank you for your presentation. Our next presenter is Mark Lochner from the Maryland Health Service Commission. And Mr. Lochner, if you have any staff, you can come on up. You can introduce your staff. Thank you. Yes, sir. Press the button on the right-hand side. Thank you.
Great, excellent. Thanks for the opportunity to come here this morning. Appreciate the invitation. For the record, I'm Mark Luckner, Executive Director of the Maryland Community Health Resource Commission. It's a state agency. We operate very, very closely with the Maryland Department of Health on a number of projects. My comments today will be focused on school-based health centers, and happy to come back again and talk about other projects that we fund. Just a little bit about our agency. We've been around since 2005. We were created by the Maryland General Assembly to expand access to health services in underserved communities. I've been here since 2009. I used to work as an aide in the Maryland House of Delegates, one legislator from Montgomery County, another person I'm sure everybody in this room knows very well, Pete Hammond. I worked for him for a while, so I get to know Baltimore City a bit. It's great. Being back here in City Hall is fantastic. Really great to be here. So our agency has awarded 850 grants, totaling $280 million. And those projects have collectively served 600,000 Marylanders. Right here in Baltimore, 110 grants totaling $57 million, and they've collectively served 260 residents of Baltimore City. Looking specifically about school-based health centers, we've been pleased to award 26 school-based health center grants totaling $6.5 million, and those projects have served collectively 20,000 children. We've been pleased to support Baltimore Medical System as an example. We've been pleased to support the Rail Center. Huge believers of school-based health centers, and if this committee wants to explore other ways to push out resources at the state level, including what Dr. Wormser's office provides, if you might, when you think about the Community Health Resource Commission, we provide highly competitive, like 1 of every 5 council members, it's very competitive. We provide highly competitive startup funding for 2 or 3 years, about $750 grand, and help provide that running room for new health centers to open and then pursue other existing ongoing funding opportunities that the state or others could provide. That's what we do. And we tailor our resources to the most unmet needs across the state, including Baltimore City. Also, we're pleased to staff and serve as the fiscal agent, all these words, the Maryland Consortium on Coordinated Community Supports. It was created under the Blueprint Bill. Dr. Connor's comments talked about that a moment. This is a huge program, huge program that we've started over the last year and a half. Really great to work very closely with Dr. Pate. She worked with our office to produce 11 consortium grants totaling $12 million. And each one of these grants had to provide a letter of support from a local education agency, and we're pleased to work with her. Bless you. And a number of those grants are up and running, including 2 school-based health center grants in the consortium funding. And there are sort of 3 things that we all keep in mind when we think about Kerwin and the Blueprint. There's the concentration of poverty, community schools, and I might add to that, our shop, the Consortium on Coordinated Community Supports. And what we were tasked to do was to create this statewide framework of comprehensive, non-stigmatized, holistic behavioral services, all kids, public schools statewide. So as I said earlier, about 11 grants, 12 million right here in Baltimore City, and we're thrilled to have those programs up and running. Many of whom will be providing services this school summer, and then throughout the next school year. And then our next funding opportunity, if I could just anticipate questions, our next funding opportunity will be this winter. It'll be available to those schools and others. We're gonna work very, very closely with Dr. Pate, and then also folks will know Behavioral Health System Baltimore. They're gonna be the organizing agency here. And then if you're interested in opening a new school-based health center here in Baltimore City, I'm hearing the enthusiasm. We have our annual call for proposals, which provides about $7 million across the state. And that will come out, let's say, between Labor Day and Halloween. So I'd be happy to provide as much information about those 2 funding opportunities, and I'd be happy to come back again. Thanks for the invitation.
Thank you. Any questions?
No, I just want to thank you, Mr. Luckner. So just to give you a little bit of background, colleagues, Mr. Luckner and I were connected through Senator Hayes, and we've been meeting on a monthly basis for a few months now to really provide the funding opportunities for expansions of these school-based health centers, and just also to provide the technical assistance so it's not necessarily an administrative or financial burden on the current agencies that operate them now. So I just want to thank you for, really pouring into Baltimore City. I know you have a love of Baltimore City, and so I thank you just for really meeting the mark. So,
Dr. Lochner, you the only presenter that my colleagues don't have no questions for, so we're gonna make
Must be
sure.
close to lunchtime or something, yeah.
You're very fortunate to stand before this committee, you don't have no questions. Thank you for your presentation, thank you for all your hard work, and the most important part, the funding source. There's always a gap when you talk about health here, and not in Baltimore City, but in the state of Maryland. Again, thank you for your presentation.
You know, I'm a state bureaucrat, and I'm just following what the Maryland General Assembly asked me to do. And you mentioned Senator Hayes. Of course, you got the Senate President. You got a great Baltimore City delegation, the budget chair, Senator McCray. You guys got great champions up in Annapolis, and as long as I follow their instructions, we'll all stay out of trouble.
Thank you so much. Our last presenter, but not least, Dr. Dobson and Davida. And if you like to introduce any of your staff and do your presentation also. Thank you.
Dr. Dobson.
Could you press the button on the right-hand side at the bottom? Yes, press the button on the right-hand side. Thank you.
Right there. I'm on? I'm live. I can hear myself. Okay. Sandra and I are here today to give a brief presentation. We're from the firm Dobson DeVonzo. On the next page, what I'll talk about today, and Sandra and I will talk together, introductions and about the firm, who we are, what we do, how we think about things, I think is really important. Background in school-based health centers, I think we'll go light on that because you've had a marvelous background today, much more than we could have ever done. And in fact, it was very, very insightful and helpful. Relevant Dobson DeVonzo work on social determinants of health. Equity is a big thing in our firm, and we worry about how resources are allocated. We're looking at some national data that show how resources are allocated relative to social determinants of health. We just published in Health Affairs, which is a journal that does worries about such things. We got a lot of work to do, don't we, in terms of equity and distributing resources in this country, and anything remotely equal to the challenges at hand as you look within a city like Baltimore and as you look across the country, one region to another. We just have a lot of work to do. And what we have to do conceptually is figure out how social determinants of health and need ties back to programs. And I heard a lot of that this morning, that you are struggling with that. Lots of programs, lots of different views on need, and not a total gestalt yet about how they all tie together just yet for you and your circumstances. So let's talk about the firm. I'm here with Sandra today, Sandra Ajik. I'm Ellen Dobson. I was the research director for Medicare when DRGs were put in place. I never tell doctors that when I go to the hospital, I'll tell you. But nevertheless, I've got some experience with healthcare finance, particularly from the Medicare and Medicaid side over the years. And Sandra comes to us as an excellent writer, a great thinker, and Sandra puts pieces together in a very remarkable way. When she's through writing something up, you'll understand it, I guarantee it. And that's really important in these kinds of complex processes. We started the firm, my wife and I recently passed away. We started it 17 years ago, and we wanted to be an economics and policy consulting firm based in the DC area. We bring an objective view. We've got a lot of trust in the people that work in the city and the various associations and such, that when we provide a product, it's our view, and it is what it is. And if they don't like it, well, they don't like it. If they do like it, that's fine too. But people know that when we pursue with the data, it's our best view of how the pieces fit together, what can be said about whatever it is we're looking at. So over the past 17 years, so we're going on 18 years now, the firm, the work of our principals has influenced the design of demonstrations, public policy decisions, and appears in legislation and regulation. We're a firm of 25 people. We've had a fair bit of reach, particularly in the healthcare policy process, and then primarily at the federal level. But we've also worked at some states and for associations, hospital associations that deal with the local issues. Next slide. We have extensive experience in multiple analytic methods. We've looked at Medicare data, we've looked at Medicaid data, we've looked at publicly available data sets. We've done a lot of economic indicator. How much, like for instance, we worked in the state of Washington. The question was, at the county level, very similar to what you folks think. What is the economic impact of community health centers? Nobody'd even asked the question before. We were the first folks in the country to put it together. And when I presented, people from counties all across the state of Washington, they said, we've never seen anything like that. The economic value, the workforce value, the tax value, the employment value of having, never mind the clinical stuff, that's a different issue. It's an important issue. Obviously, it's the key issue. But the economics are important too. And you find that when you provide care, you're also supporting the economy of the area, and you're supporting, and it said, your workforce, et cetera, is supported by as the children then go into the workforce. We've done a lot of work with economic indicator data, survey data. Of course, we do statistical analyses. And we do work with, I think, something that's really important to you folks. That's data that aren't generally available, that aren't generally understood, come from disparate resources, and are really, really, really difficult to tie together. I've heard a lot of excellent presentations this morning, but how they fit together, the gentleman on the right was asking questions pretty steady there, my right. How do these things fit together? How many basic kinds of statistics do you have that tie these programs together across the various areas? What do you know about what you're doing in its totality? And I think that's one of your main questions. What is the totality of your effort? How do the pieces fit together? Are they meeting the objectives? And it's not altogether clear from listening to this that you have the answers to those kinds of basic questions. And that's something that our firm has spent a lot of time with over the years, helping people understand very, very complicated, disparate activities, how they fit together, what they mean to the community, and are they meeting the needs of the community. So we look at the economic impact model, look at employment, tax, and income data. You may or may not be ready for something like that now, but ultimately, I think that that's very important because it says I saw one thing that said for every dollar invested, you had a social return of $4 or something. It turns out that the economic multipliers are quite high, usually 2 to 3. You put $1 in a community in healthcare, and you usually get $1 back in tax, a couple, $3 back in taxes, employment, and the rest of it. So we do what's called mixed methods analysis. And the mixed methods really just means you look at things from different perspectives. You triangulate. Quantitative, everybody understands quantitative data, at least they think they do. Most of us like to think we know more than we do, I think, but that's beside the point. But you want quantitative analysis. But importantly, and Dr. Devanza, who founded the company with me, recently expired, she was so big on qualitative analysis. She had her PhD in public health from UCLA, but she focused on every study, qualitative analysis, survey tools, talking to people. What do they think? How do they understand the process? Do they understand how it ties together, et cetera? Technical expert panels, public listening, like we're doing this morning. We're learning so much about how you folks are thinking about your problems. And then expertise and literature reviews. We always found, start with a literature review, set up the database, whatever database it's going to be. In your case, the data would be what you all think about what you're doing and what you are doing, and the disparate pieces, how they fit together across the various sites, and how they tie together in terms of what. And I think that's the issue, how they tie together in terms of what. Now, all that said, we think a lot about partnerships. And I don't know if we'll ever have a partnership with anybody in this room. Maybe we will, maybe we won't. But some of our partnerships, we've been in business 17 years, but some of our clients go back 30 years. I was at Lewin Group for 19 years, and I bring those clients along for like 25, 30 years. Once you get a partnership going, then you start to understand a consultant is only as good as the understanding of the phenomena they're looking at. You guys know it better than most consultants ever would, but the longer you work together, and the more the consultant works with you, and the more you work back with the consultant, the better the mutual understanding is the things we bring, the tying together. This is kind of an odd analogy, but consultants are like little honeybees. They fly around and pollinate, and they talk to this one and talk to that one, and pretty soon you have a much better understanding of what is going on in the community vis-a-vis the activities of so many disparate things. So it's really important, I think, to have partnerships, to have long-standing relationships, and to understand what we do, and we understand what you do, we tie it together, and we work through time to get some sort of I used the word gestalt a bit ago, but a gestalt about what it is that's actually going on. So what I'll do now is turn it over to Sandra, and she'll present the next part of the presentation.
And I'm sorry, Dr. Dobson, if it's possible, we can condense the presentation down to 5 to 7 minutes, given that most of this information has been presented in other presentations. Thank you
Sure.
so much.
Definitely. Good morning, good afternoon, everyone. So I will go over the rest of the presentation and we'll try to make it brief. I think most of what we've talked about this morning is covered a little bit here. And so in terms of background and context, we've all heard this morning and probably know from our work that school-based health centers provide healthcare services like primary care, preventive care, mental health care, and sick visits, as well as on the chronic side of things, managing that care for the students and communities and families that need it. I think there's an important piece about closing health equity gaps that's been highlighted throughout the day as well. Just showcasing here, if we are talking about the topic of health professional shortage areas or medically underserved areas, this is some data that we obtained from the Maryland School-Based Health Center Assessment. That again highlights, if you see the onset on the bottom left, showing that for the dark gray parts where you have both medically underserved and health professional shortage areas, you do see a lot more of the school-based health centers, but it seems like there's still potential there. There are other ways to think about social determinants of health and understanding the needs of a community. A few of the factors that we have listed on the slide, in our work at Dobbs and Devanzo, we have explored and tried to map out and understand the extent of the sort of lack in the different communities. So some socioeconomic factors like children in poverty or income ratio and food environment index and so forth. We've been able to develop an index that shows within the different, here we have Maryland, and basically the overall score goes from 0 to 100, with the higher indicating that you're more vulnerable. And as we know, as we see, based off of the metrics that we've talked about, definitely seems like there's a lot to be done within Baltimore City specifically, highlighted in the circle. And so in our work, some of the questions that we would ask would try to overlay where are some of the greatest needs, what are those needs, and how do they intersect with the schools that have school-based health centers and the ones that do not, and things like that.
Sandra, if I may, we've done a lot of work with this slide at the national level, and it's fascinating how when you do social determinants of health and you put it in a chart like this, places like Appalachia just jump right off the page. And it's kind of like it took a long time to get where we are. It's going to take a long time to get out of where we are, but at least you got to know where we are. And we were able to chart this stuff in such a way that when I first saw our Appalachia slide, I said, wow, I've heard about this for 50 years, but I've never seen it quite so graphically. We got some work to do in Appalachia, just as a for instance. And that's sort of a little bit of a summary that we could take that and break it down and blow it up in more detail and give you a lot of understanding about the basic social determinants of health and the extent to which you've got the variance in them across your areas and where your dollars are going. Do they apparently track that or not? I don't know that they do or they don't, but we can figure that stuff out with the data we have. We built our own index, other people have indexes, but Sandra just showed you the kinds of things that we comprise ourselves. We got it at the 5 zip code level, so we're pretty detailed with it. We can go in and say at the 5 zip code level, what are the social determinants of health, and then try to track back all the kinds of things we've heard in the room this morning and say, are they correlated or not? I don't know that they are. I think one gentleman thought maybe they're not so correlated, just intuitively, and I think that's been one of the comments from the up forward here. Okay, Sandra, thank you.
Yeah, and then the last couple of slides, I think in terms of potential evaluations, right? The literature is pretty strong on the evidence of the impact of school-based health centers. I think the gap there is, what does that mean when it comes to Baltimore City, right? Like, we can have national numbers, we can have the wide range of the money needed to invest and start up a school-based health center and the return on investment. But I think what could be important as we continue to make evidence-based decisions is, what is it that school-based health centers help impact within Baltimore City? So what's the impact on access and healthcare outcomes for the schools that have them in comparison to the schools that don't? And then the second piece there that Dr. Dobson mentioned earlier is, we like to look at the economic impact as well. So going just beyond healthcare, what is the impact on the economy within the communities that do have these school-based health centers? A little bit more detail here. There's plenty of data available. Our analytic methodology, I think, at this stage, we do want to be rigorous and make sure that we're comparing sort of at the scientific statistical level for schools that have school-based health centers, which is the test group, to a comparison group, and looking at the different outcomes of interest. So in one case, we could look at the health outcome measures that I think we have strong evidence in the literature about, but it would be important to characterize for Maryland, for Baltimore City specifically. And so that's sort of your healthcare outcomes type impact study. And then on the economic impact side, we could also look at, okay, for the X amount of dollars invested in starting a new school-based health center, what does that mean in terms of the economy around the community, as well as what's that return on investment in terms of dollars as well. So that brings me to the end of the presentation.
Thank you. Thank you for your presentation. My other colleagues don't have a question. My question is, who do you talk to? Where do you get your data from? What community you go to? Because this looks good, but who did you talk to?
I'm going to read you up there. I'm having trouble with this room, so I'm going to read you up there.
Let me finish. Who did you talk to? What community did you talk to? What community you go in to get this information?
So I think in terms of our day-to-day work, is that the question?
You have this data that you presented, right?
Yep.
You have a nice map. So my question is, who did you talk to? What community, what schools did you talk to?
Sure. Yeah, so the data that we shared on the school-based health centers comes directly from the Maryland assessment report that was put online. In our own work that we do, Dr. Dobson mentioned earlier that, for example, pulling from the work that we're doing in Appalachia within states like Kentucky and things like that, we try to understand and dissect some of those healthcare indicators. So it would be an application of sort of our experience working in states where they have disparate healthcare issues and then applying it to Baltimore City. So none of the work we have done so far within Baltimore City, but we're showcasing examples of things that we could do.
One thing that we're doing now you might find interesting, we've been asked by a national organization to look at closure of hospitals in rural areas. And what happens? Well, it hurts the economy, it hurts the population. And then what do people replace it with? Oftentimes with community health centers, oftentimes with mergers and acquisitions. And the whole relationship between how community health centers and school health centers link back to the broader healthcare environment, I think, is real important. And in the rural areas, when you tie together a hospital closure and then you have mergers and acquisition, maybe you bring in broader healthcare systems like the Hopkinses of the world come in and they help strengthen the rural area. It's real important to have the community health centers, but they do different things. And to know what the different things are about the health centers as opposed to the hospitals and the physicians and the systems is awfully important because you want them to work together somehow, and oftentimes they don't. And it's really important, I think, and what we're studying is we're finding out the health centers have a different role, and when a hospital closes, there's a need to do something, but you got to figure out what that something is and how it affects the community. Like here, in your situation, there's a need to do something, but you just got to figure out how it fits into a broader whole, how it fits with the Medicaid program in particular, and how it fits with the other delivery systems. The one thing about the community health centers, the school-based systems, the immediacy. And that just jumps out of the presentations we've heard this morning. Your stuff is fast because you're right there with the kids. You don't have to wait 3 months to get a appointment because the nurse is on duty. So the immediacy is very important, but also the other kinds of things that provide in the broader health community, they're important too. And tie them together in some way that makes some sense, I think, is real important. And we're working on that at the broader national level for this one client. Community health centers, closures, mergers, acquisitions, how all that ties together to make rural healthcare stronger in this country.
Thank you so much for your presentation. I guess that's the only question I have. My colleagues don't have any. Before I make a motion,
Thank you.
You have a question?
And finally, I just want to thank you all for your presentation as well. And just for the public, the reason why I asked them to present today is one, to begin to that discussion about the economic impact of school-based health centers. I know that there were some data that was presented in the 2022 assessment, but post-COVID, we need to really reassess how healthcare centers throughout Baltimore City can be expanded, and how that economic impact is not only reinvested in our communities, but also will be providing some of the healthcare outcomes that we need to see throughout the city. So thank you.
So thank you. Before I make a motion to vote on this resolution, I'm going to turn it over to Councilman Porter to see if she have any closing remarks. I guess that might have been your closing remark.
It was. I just want to thank you all for presenting today. I know we had quite a few presentations. We had quite a lot of information, but really kind of threading the needle between city, state, and federal dollars that can come into Baltimore City to expand school-based health centers, to make sure, like Councilman Torrance was just mentioning, really increasing positive healthcare outcomes throughout Baltimore City, and not just within communities that are surrounding school-based health centers, but also to all communities. So I thank you.
Well, I'm just excited to know all these agencies are now talking about, when you talk about health, if we not sharing information or not talking to each other, that's that gap. So I'm really excited to know a lot of the agencies here are now working together to address some of the health issues and clinics and nurses in the city. And I appreciate your work and working together. So we're gonna go ahead and have a motion to vote on council resolution 23-0200R. Motion by, I make a motion. Second by Councilwoman Porter. Is there, no, who's gonna make the motion? I need a motion. Okay. Councilwoman made the motion. Is there a second? Second by Councilman Bullock. Stokes says yes. Councilman Bullock? Yes. Councilman Cohen is absent. Councilman Dorsey is absent. Councilman Torrance?
Aye.
Is a yes. Councilwoman Porter? Thank you so much. The motion passed. The resolution be placed on second read at next council meeting. Thank everyone for attending. The hearing is now adjourned. Thank you so much.